ผมส่งสไลด์ให้ในเมลเดิมนะช่วยกระจายให้เพื่อนหน่อยนะครับ
มีไฟล์เดียวใช่ไหมคะอาจารย์
เดี๋ยวเอาไปไฟล์เดียวก่อนเดี๋ยวตอนบ่ายมีอีกไฟล์หนึ่ง
ได้ค่ะขอบคุณค่ะเรียบร้อยแล้วค่ะ
โอเคครับถ้ามาครบแล้วบอกหน่อยนะจะได้เริ่มเลยเพราะว่ามันจะค่อนข้างเข้าใจยากหน่อยเราอาจจะต้องกลับไปทบทวนไปอ่านเพิ่มครับ มาครบแล้วเนาะงั้นเริ่มผมเริ่มเลยนะ
โอเคค่ะ
Okay, so good morning, everyone. Today's topic is atrial ventricular nodal reentrant tachycardia. Uh, anyone know what is this tachycardia is? Uh, you can guess if you don't know anything about it, you can guess what it is.
It's a kind of supraventricular tachycardia.
Yes, it is. It's one of the kind of the supraventricular tachycardia. Okay, so I assume that you all have some basic knowledge about the SVT. Okay, so this is the outline today. First of all, I will talk about the anatomy and electrical system of the heart, similar to the last lecture, but this is important for the basic knowledge of the Abnrt. And I'm going to talk about the ECG presentation and how to approach the regular narrow QRS complex tachycardia. This is equal to the SVT. And we will dig deep into the details about the type of Avianity and how to diagnose it with the electrophysiological feature. And lastly, we will talk about the treatment of this type of arrhythmia, which is ablation. Okay, so let's start with the anatomical and the electrical system of the heart. As you have known before, the electrical system of the heart consists of the signal from SA node, which is the normal sinus rhythm in a normal person. And the signal will travel along into the AV node and then spread through his bundle and throughout the region of left bundle and right bundle branch to the ventricle. Um, this is in normal people. And what we are going to talk about today is the arrhythmia that occurs inside the AV node, which is there is a small reentry circuit inside the AV node and causing the SVT or the Avianity. This one is the concept of the AV node anatomy and physiology. If you look inside the AV node, uh, there's two concepts about it. The first one is old concept. On the left side, it said that the AV node is a compact area, the area which the cells would receive the signal from the atrium, and then this cell have some property to delay the signal from atrium before sending the signal out to the hisbundle region and to the ventricle. The old concept of AV node only state that the AV nodal cells are in only one area, which is called compact AV node. But later on, into modern days, the electrophysiologists have found that there is the theory of compact AV nodes is true, but there is some parts between the AV node and the atrium, which is called the transitional zone. The transitional zones is the zone which the cells has some property of atrium and also some property of the AV nodal cells. And the signal will travel along the atrium into the transitional zone and then reach the compact AV node, which has the property of delaying the signals before sending them into the hisbundle and ventricular system. This is one of the most important slides in this lecture. The anatomy, which is called Triangle of Cork. This is the area in which the reentry circuit is formed, and this is the area which we have to identify before we do the ablation. The triangle of Cork is formed by three structures. The first one is the tendon of Toledo. Here, this one is one limb of the triangle. The second one, the roof of CS, is the base of the triangle. And another limb of the triangle is the tricuspid annulus. This triangle is where we identify the compact AV node. The AV node system is in the top of the triangle. You have to remember this. This also will be in my my test about this lecture. And the reentry circuit is around here inside the triangle. Okay, and this is the view of the anatomy of the electrical system of the heart in when we have when we look at the RAO view and the LAO view. The RAO view is right anterior oblique view, and the LAO view is the left anterior oblique view. This is the view when we use the fluoroscopy to see the heart during the ablation. Okay, so as you have said before, that the Avianity is the subset of supraventricular tachycardia. So what is the supraventricular tachycardia? It is a form of arrhythmia which is a narrow complex tachycardia. The QRS would be less than 120 milliseconds on the 12-lead ECG, and the rate would be more than 100 beats per minute. This tachycardia, which is narrow complex, is likely to generate above inside the AV node or above the AV nodal system. So the first supraventricular tachycardia is originate from the sinus. Two of the kinds is inappropriate sinus tachycardia and the sinus node reentry tachycardia. And also the atrial tachycardia is one of the kind of the supraventricular tachycardia. Atrial flutter is also the SVT. And the topic today, the Avianity, is another kind of the SVT. And also the topic in the afternoon, the Avrt or atrial ventricular reentrant tachycardia, is also the SVT. So basically, you can say that every arrhythmia that originate above the ventricle is the supraventricular tachycardia. There's also other types, such as the junctional tachycardia. It is also one of the supraventricular tachycardia. So, what is Avianity? The Avianity is the reentry circuit inside the AV node. It is a very small reentry circuit which cause the electrical signal to circulating inside the AV node and causing the tachycardia. This you have to know what is reentry first. Can anyone tell me what is the reentry? You can guess. Oh, okay. I will ask you first. Do you have a lecture about the mechanism of arrhythmia?
Yes, Achan.
Okay,
It's
so
like anatomical or functional reentry, something like that.
okay, so what is it? So what is the reentry?
Reentry is like the signal moves in a circular pathway. The
Okay,
signal, the conduction of the uh, electrical signal from the origin side, it moves in a circular pathway instead of conducting it down to the ventricle.
okay, you answered it correctly. So this is the reentry pathway. Uh, they must have two limbs of conduction pathway. One is a slow pathway, and another one is a fast pathway. The two limbs of conduction have to be different in property that they could conduct the reentry circuit. And you have to have the core of the reentry, which have to be a refractory tissue that the electrical signal could not conduct through this area. When we have two different the difference of pathway, two pathways. One is the slow pathway, which have a shorter refractory period, and another one is a fast pathway, which have a longer refractory period. In an and in a normal situation when the patients have a normal sinus, the electrical signal would conduct from the sinus through the atrium into the AV node, and it would spread through both of the limbs. And when we have a conduction through the fast pathway, the conduction would likely to spread through the AV node and into the ventricle. But the conduction in the slow limbs are so slow, and it could not compete with the conduction through the fast pathway. So it would collide into the refractory period after the signal of the fast pathway have passed into the ventricle. So this would not likely to result into a re-entry circuit or a re-entry tachycardia. But when something occurs, like the trigger of the premature atrial complex or the ectopic beat, this would happen during the refractory period of the fast pathway. Because like I said before, the fast pathway have a longer refractory period, and the slow pathway have shorter refractory period. So when the PAC have come, the fast pathway is still in the refractory period. It could not conduct anything, but the slow pathway, which have a shorter refractory period, have already recovered, and the signal from the ectopic beat could result in conduction through the slow pathway. The conduction through the slow pathway is slow enough to let the fast pathway to recover. So when the signal arrive in the fast pathway here around this area, the refractory of the fast pathway have already ends, and the fast pathway have already recovered. So the signal from the slow pathway could travel up into the fast pathway and causing the re-entry tachycardia. This is the concept of the re-entry. So when it is come to the AV nodal re-entry tachycardia, this is the AV node and the re-entry inside it. There is low and fast pathway. Like I said before, if the patient has the sinus rhythm, it can only conduct, it could conduct through both pathways, the slow and the fast. But the signal from the slow pathway is so slow, and it would collide it into the refractory period of the fast pathway. The result of the ECG is the sinus, like normal patients. And here in the second picture, the sinus from the sinus node, the signal from the sinus node could also conduct through the slow pathway and reach the ventricle, and this would result in a normal sinus rhythm, but the PR segment is longer than the conduction through the fast pathway. And for the last picture, this is the reentry tachycardia, in which there would be a trigger. The trigger is mostly the premature beat of the atrium or the ventricle, and this would result in a reentrant tachycardia. So, the atrioventricular nodal reentrant tachycardia is the reentry in the area of AV node and represents the most common regular arrhythmia in the human. Another word that we used to call, we use all the time to call both the slow pathway and fast pathway, is the dual AV node pathway. Most of the people have only single AV node pathway, which is the fast pathway. But there is around 15% of the population who has a dual AV node, who has both slow pathway and the fast pathway. But not all of them would likely to result in the tachycardia. Some of them have dual AV node physiology, but uh, they do not experience the tachycardia. So this is the fast and slow pathway in patients with the Avianity related to Cox triangle. If you could remember that I have said before that what is the Cox triangle, and here is the fast pathway inside the Cox triangle and the slow pathway inside the Cox triangle. And this is the real anatomy of the patients. This is the area of Cox triangle and the fast and slow pathway, which could form the Avnrt. There's types of Avnrt. The typical Avnrt and atypical Avnrt. The EC12 leads ECG is similar, both of them. There's some difference, but it is a narrow complex tachycardia. The difference between two types is the reentry circuit. The location of the slow and fast pathway and the direction of the reentry is different. So it would result in a slightly different 12 leads ECG. I will talk about this in details in the next couples of minutes. And there is a superior input or the anisotropic atrionodal transitional area. You don't have to remember this. This is just a term about the anatomy of this transitional zone that I have talked before inside the AV node that would likely to result in the tachycardia. So how to diagnose the Avianity? First of all, we use the 12 leads ECG, but the 12 leads ECG could not give you the definite diagnosis of the Avianity. You could only say that it is, you are sure that it is SVT, but it just it's just a probability that it is Avnrt, Avrt, or the AT, but it cannot give you a definite diagnosis. So we have to do the electrophysiology study. We have to put the catheter. 4 catheters are required for the diagnosis. The first one is the right atrium. The second one is the His catheter. The third one is the CS catheter. And the last one is the RV catheter. 4 catheters are required for the diagnosis. And for most of the patients, we usually put the ablation catheter in. So if we have the definite diagnosis of Avianity, we could ablate right away after the diagnosis. So what is the ECG presentation? Surely it is a narrow complex tachycardia, and it have to be regular narrow complex tachycardia. The next thing we usually do when we see the SVT ECG is we have to identify the P wave. Is it visible P wave or not? Or what is the P wave look like? If the P wave looks like a sawtooth appearance, we could diagnose that it is atrial flutter. But if it is not a sawtooth appearance, we have to see that it is visible or not. If it's not visible, the narrow complex QRS is not without P wave, it is likely to be typical Avianity in this limb. Because that the reentry circuit of the AV node was so small, the P wave usually blends into the QRS complex. So if we do not see the P wave during the SVT, the first diagnosis would be typical Avianity. But if we could see the P wave here in this limb, we have to see if the P wave, if the atrium rate or the ventricular rate, which is faster. If the atrium rate was faster than the ventricular rate, it is likely to be atrial flutter or the atrial tachycardia. But if the atrial rate is not faster than the ventricular rate, we would come to the next analysis of the RP interval. RP interval is the interval between the peak of R wave to the start of the P wave. If the RP is shorter than the PR, or the RP is longer than the PR. If the RP is longer than the PR, or the long RP tachycardia, the diagnosis would likely to be atrial tachycardia, or the paroxysmal junctional reentry tachycardia, or atypical Avianity. But if the RP is shorter than the PR, also called the short RP tachycardia, we would have to see if the RP is less than 70 milliseconds or more than 70 milliseconds. If the RP is less than the 70 milliseconds, it would likely to be a typical Avianity. As I've said before, the reentry in the AV node was so small, so the distance between R wave to P wave, the AV node to the atrium was so short, so it would be less than 70 milliseconds. But if it is other tachycardia that, like the Avrt, the distance between the reentry circuit to the atrium is quite long or longer than the Avianity. The RP interval would likely to be longer than 70 milliseconds. So this is the regular narrow QRS complex tachycardia. Can anyone read this ECG for me? Step by step, as we have mentioned in the last diagram. Okay, anyone, don't be shy. Is it all right if you cannot read it correctly, but you will learn from it. Okay, so if there is no one, first of all, it is a narrow complex tachycardia with a regular rhythm. Everyone sees that, can see that, and the next thing we have to do is to identify the P wave. So where is the P wave? I think the P wave is here. 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 The P wave is the small here after the QRS complex. Or you could say that you cannot identify the P wave clearly in this ECG. So if it is not visible P wave or it is not clear, you can go back to this. It is no P wave, no visible P wave. It would likely to be a typical Avianity. Or if anyone say that the P wave is very short in duration, and if we see that if this one is the P wave, we have to see that the atrium rate and ventricular rate is which is faster or which is slower. So in this patient, the atrium rate and ventricular rate is likely to be equal. So we have to see that it is short RP or long RP tachycardia. This one is the RP. This is R and this is P wave. Compared to the P wave, the P and R interval. This one is RP and this one is PR. So in this patient, the RP is shorter than the RP. Oh, okay. The RP is shorter than the PR. So it is a short RP tachycardia, like in this. So it comes to this limb. And we have to see that what is the RP interval of this patient. So you can see that this is very short. It is less than a small one box square of the ECG. So it is likely to be less than 70 milliseconds. So we can diagnose that this patient is likely to have a typical Avianity. Okay, anyone has any questions about this?
อาจารย์ครับ can you explain once again the
Okay.
point, the arrow which you have pointed as a P wave?
Okay. Okay. I assume that this is the P wave. I assume that this is the P wave. So after we see the P wave, we have to see if the atrium rate is faster than the ventricular rate or not. In this patient, the P wave ratio and the QRS ratio is likely to be 1:1. Is that correct? So if the P wave ratio to ventricular to QRS is 1:1, the atrium rate is not faster than the ventricular rate. So we come down to this limb of the diagram. We have to analyze the RP interval. So what is the RP interval? The RP interval is the interval from the R wave to the beginning of P wave, which is here, the RP. The RP is at this one. The peak of R wave to beginning of P wave, and we have to compare it to the PR interval. The PR interval is the beginning of P wave here to the peak of R wave in the next beat. We can see clearly in this ECG that the RP interval is much shorter than the PR interval. So we diagnose it as a short RP tachycardia. After we know that this patient has a short RP tachycardia, we have to see how long is the RP interval. Is it less than 70 milliseconds, or is it longer than 70 milliseconds? In this patient, the RP interval is very short. It is likely to be less than one square box of one square small box of the ECG. So it is likely to be less than 70 milliseconds. So we can diagnose this a typical Avianity. Is it clear for you now?
Jan, it's clear, but what is this wave between the two RR interval at the lead second?
Which one?
The one which you have marked as a P wave. Next to it, we have a little positive wave.
Oh, this one is T wave.
Oh,
this one is T wave. Yeah. The P wave in the leads, the limb leads, the 2, 3, and the AVF leads are in this kind of tachycardia is likely to be a retrograde P wave. So it is likely to be an inverted P wave in the inferior leads. The P wave is likely to be inward here. But usually in the clinical setting, we diagnose the SVT, and sometimes we cannot identify the P wave clearly, or we are not sure which is P wave. We don't have to give the definite diagnosis right away. We have to do a further study of electrophysiology. So if you cannot identify it, or if you are not sure about the ECG, you don't have to be so serious about it. You at last, or you have to do the definite diagnosis of the electrophysiologic study. Okay, so can we move on now?
Yes, Ajahn, thank you for the explanation.
Okay. So this is the list of a short RP tachycardia and a long RP tachycardia. You can see that both of short and long RP, there's sometimes the Avianrt, usually the Avianity is short RP, but there's some type of Avianity that is long RP, and also there is some types of Avrt which is short RP, and some are a long RP. There's an overlapping of both of the tachycardia, so you cannot tell, you cannot use the 12-lead ECG to give the definite diagnosis. You just have the probability of the patient of the arrhythmia types. You need an EPS to confirm their diagnosis. Okay, so this is the example of the short RP tachycardia that I have mentioned to you before. In the A scale, in this scale, the Abnrt, for 56%, you cannot identify P wave because it is inside the QRS. 36% have a very short RP interval just next to the QRS, and 4% have the P wave before the QRS, which is a long RP. If you have another QRS config, it would be like this, and you measure here R to P. This one would be long RP, which is a typical form of Avianity. And 4% have short RP, but the short RP is longer than 70 milliseconds. So you can see that it is not the definite diagnosis from the ECG. Okay, and if it is an accessory pathway or the Abnrt, for 100% it would be a short RP, but it is likely to be longer than 70 milliseconds. There's no Abnrt that could not visible P wave. The P wave could not be blended with the QRS if it is Abnrt. Okay. Just for the information, this photos, the intention that I put it in here is that to tell you that you could not give the definite diagnosis, but only by the 12-lead surface ECG. We came to the types of the Avianity. There are 5 types of the AV nodal reentry tachycardia. Usually we put into 2 subsets: the typical Avianity and atypical Avianity. And in a typical form, there are 4 types. The typical Avianity, we have to measure the HA interval. The HA is similar to the VA interval, but we measure inside the electrophysiology, and the H is the his signal to the A signal is less than 70 milliseconds. The VA interval is less than the 60 milliseconds. VA is the ventricular signal to the atrium signal, and the ratio of AH to HA is more than 1. If we measure this during the tachycardia inside the electrophysiologic study, we could confirm that this is typical Avianity. But if it is a typical Avianity, the HA interval is usually more than 70 milliseconds. The VA interval is usually more than 60 milliseconds, and the HA to AH to HA usually variable. This is from the study of Dr. Knight. He collected the SVT from the electrophysiologic studies and see if what types it is, and you see that the Avianity, usually typical Avianity, consists of 51% of of all Avianity, and this is the most common tachycardia. The cycle length usually 329, around 350 in both types of typical and atypical Avianity. And the VA interval of the typical Avianity is much shorter than the atypical Avianity, usually shorter than 70 milliseconds. And in atypical Avianity, the VA interval is more than 60 milliseconds. So this is the anatomy of typical Avianity. There is 2 pathways here. Here is the fast pathway, and here is the slow pathway, which used for the reentry circuit. Here, this is the RAO projection, and this is the LAO projection. So what are the types of the Avianity? The first one is typical slow fast Avianity. What is slow fast? The slow fast is when the tachycardia use the slow pathway as the anterograde pathway from up to down. This tachycardia use the slow pathway and use the fast pathway as the retrograde limbs. The slow pathway in this type is in the location of rightward and inferior extension of Cox triangle. The second type is slow fast Avianity. Oh, sorry. This one is also slow fast Avianity, but the slow pathway is in the different location. It is in the leftward inferior extension of Cox pathway. This one also use the slow pathway as the anterograde limbs and fast pathway as a retrograde limbs. And also some types which is a slow Avianity. The patient has both slow pathway inside the Cox triangle and it used both slow pathway as a reentry circuit, which is counterclockwise reentry. And the last classification is fast slow Avianity. This type use the fast pathway as the anterograde limbs and use the slow pathway as a retrograde limbs. So it is a clockwise reentry circuit. I will have anatomy in the next slide, and I will explain it to you again. This is the typical slow-fast Avianity. The slow pathway is here in the rightward inferior extension of the Cox triangle here. In this tachycardia, it used a slow pathway as the anterograde limbs and use the fast pathway as the retrograde limbs. Here is the right inferior extension of the slow pathway. It is the most frequent used slow pathway in the Avianrt, so we call it a typical Avianrt. And this is the second type, the slow pathway in the left inferior extension of the Cox triangle here in the middle and in the left inferior extension. This is the second type. And the third type is slow Avianrt, in which they both used both slow pathway as the retrograde and anterograde limbs of the tachycardia. And the last one, so this is they use both the rightward and leftward inferior extension of AV node as a reentry circuit without using a fast pathway. The last one is the fast slow reentry circuit in which the tachycardia use the fast pathway as an anterograde limbs and use a slow pathway as a retrograde limbs of the tachycardia. So it is a clockwise tachycardia. Here is a fast pathway. Here is ventricle, and here is atrium. So in this type, the tachycardia use the fast pathway here as a anterograde limbs, and use the slow pathway here as a retrograde limbs. These pictures have the side of the ventricle and atrium is switched. The ventricle is up and the atrium is in the down side. So there are types of it, but um, you don't have to identify all types of the Avianity to treat the patients. The types is just for for the diagnosis and for the research of the mechanism of tachycardia. In the real clinical setting, uh we could identify the types, but it is not essential for the treatment. They are the treatment of all types are the same. We use the ablation around the same area, and we also, if the patient doesn't want to do the ablation, we give them the beta blocker or the calcium channel blocker, which is the same medication in all types of Avianity. So here we are going to talk about the electrophysiological feature of Avianity. This part is the most important part for you. Uh, you you will have to use this if you want to be an electrophysiologic physiologic technical in the EP lab. Okay, how to diagnose Avianity? What we have to focus on. First of all, we have to focus on the onset of Avianity, how it is occurs. Second of all, we have to focus on the termination of the tachycardia. The third one we have to see is the wobble. Well, I will talk about what is wobble is in the next few slides. The third one you have to see is the PVC during the tachycardia. What could the PVC do to the tachycardia? And the last one, the parahisian pacing. So I will talk to you again about the standard diagnosis EP catheter. As I have said before, we need 4 catheters: high RA, the HIS catheter, the CS catheter, and the RV catheters. Some of the doctors would put uh, a lot of HIS catheter. Uh, they can put in proximal HIS catheter, middle HIS catheter, and distal HIS catheter. But usually, I usually put only one HIS catheter in the patient. And here is the LAO projection of all the diagnosis catheter. So as you can see from this slide, there is a signal. This is when you put the catheter inside the patient and it is doing the sinus rhythm, you could see that the high RA would come first here. The onset of the signal of high RA is the first signal that reach the catheter, followed by the atrium signal in his catheter, and followed by the atrium signal inside the CS catheter. And you could see that the RV catheter could not detect the atrium signal because it is in the RV. There's no part of it which contact the atrium. And if you look at the His bundle electrogram, you could see that the next signal that would be appear on the His catheter would be His signal. And after that, you would see the ventricle signal in the His catheter. For the RV catheter, you could only see the ventricle signal here. This is the normal sinus rhythm and all the signals that you could see in the catheter. This is the real one. here is when you pace, this is the pace, this is the signal of pacing. You could see the pace spike here. This one you pace from the high RA. If you pace from the high RA and if it capture the atrium, it would result in the capture signal of atrium here in high RA. And after the stimulus travel along into the his area, you would see the next of the atrium signal is the his signal and the ventricular signal in his catheter. And in the CS catheter, this one is the atrium signal from the stimulus from the high RA catheter. And here, this one is the ventricle signal in the CS catheter. And this is RV catheter. You could see that there is only RV signal here in the RV catheter. Oh, I have to tell you first that the sequence of the catheter you can switch the sequence. Some doctors prefer to have RV signal up above here, and some prefer the RV signal down below the CS catheter. You can switch as you like. If you graduate and go to work in the EP lab, some doctors would also switch the CS signal. Some of them would switch the CS 1 and 2 up here and 9 and 10 down here. It's just a preference of the doctor. Don't have to be serious about it. So not only you see the intracardiac electrogram signal, you have to look at the surface ECG here during the EP study. The surface ECG inside the EP study also could give you a lot of information about tachycardia. So this is the step for the diagnose of the SVT during the EP study. We do the ventricular pacing to see the retrograde atrial conduction, to see what is the response of the retrograde, the types of retrograde atrial conduction, what it is like. If we do the atrial pacing, we would like to see if there is a dual AV node physiology pathway. Do we have an AH jump? If we pace the atrium, if it is a bypass track, it would likely to increase the pre-excitation that you would see in the surface ECG. During the EPS, you have to see that if it is narrow QRS complex or not during the SVT by using the surface ECG during the EP study. You have to see if it is Y complex regular tachycardia or not by using the ECG. And the irregular tachycardia or regular tachycardia, you could identify it from the surface ECG during EPS also. This is the ventricular pacing tracing. This is when you pace the RV here. Here is the RV pacing inside the CS catheter, and this is the ventricular signal here. This is the pacing spike, and this is the capture ventricular signal. And this one, the last signal here is the retrograde atrial conduction. You have to see the pattern of retrograde atrial conduction. Which catheter is the fastest retrograde atrial conduction, which is the slowest retrograde atrial conduction. Like you can see from this this tracing, the fastest retrograde atrial conduction is in the his area, and it goes along up the slower of the retrograde atrial conduction is in the CS9, 10 up to CS1 and 2, and the slowest retrograde atrial conduction is in the high RA. This pattern is called a concentric retrograde atrial conduction. I will talk about this later in the later slide. And here, in the right picture, this one is also an RV pacing. Here you can see that there is a spike here and a capture RV. And in the CS catheter, this is a capture RV. This is atrial signal, which is a retrograde atrial conduction from the signal comes from the ventricle up to the atrium. This one you can see that the distal CS signal has the fastest retrograde atrial conduction here, up to here, and the slowest retrograde atrial conduction occurs in the high RA. This is also called the concentric retrograde atrial conduction. Oh, sorry. This is the eccentric. This one. Sorry. I will explain it again. This one. The distal CS is equal to the CS1 and 2, 1 and 2, and the proximal CS is equal to the CS9 and 10. So in this photo, in this picture, the retrograde atrial conduction occurs first in the CS1 and 2, and occurs faster than the CS9 and 10 and the high RA. So this one is called the eccentric retrograde atrial conduction. Okay, about this slide, anyone has any questions? Okay, so when we do the ventricular pacing, we have to see which types of the retrograde atrial conduction, the concentric or the eccentric. If it is concentric, it would likely occur first in the his bundle catheter, and if you don't have his bundle catheter and the CS9 and 10 before the CS1 and 2. But if it is eccentric retrograde atrial conduction, the atrial signal would likely to be seen in the CS first, and after that in CS9 and 10 and his bundle catheter. And also this is the ventricular in the Avianity, the pattern of retrograde atrial activation would have to be a concentric retrograde atrial activation. If you do a ventricular pacing during the EPS and you see that it is eccentric retrograde atrial conduction, you could rule out the Avianity. And can anyone read this ventricular pacing for me? Which is ventricular pace and which one is the retrograde atrial conduction? Which type of it? It is eccentric or it is concentric? Okay, first of all, you have to identify which is ventricle and which is the atrium. Which is the ventricle? The easiest way to see if which is that you identify first from the 12 lead ECG, and you see that this is the QRS, and if in the EGM is in the same timing of the surface lead, so this is the ventricular signal, because you see the QRS at the same time. This is the V pacing signal. And where is the atrium? So the atrium could be easily identified in the hierarchy. So this is the hierarchy catheter. This is the atrium signal, and you see that the signal that comes in the similar timing as the atrium signal in hierarchy here. So this is the atrium signal. This is likely to be a retrograde signal because we pace ventricle and it is went up into the atrium. And the next thing you have to see is in which catheter the signals of the atrium come first. You see that in the His catheter here, the signals of atrium has come first, followed by the CS 9 and 10. And the signal in the CS 1 and 2 is the slowest retrograde atrial. It is likely to be it is not likely to be an eccentric, because if it is an eccentric retrograde atrial conduction, the CS1 and 2 have to be the fastest retrograde atrial activation. The CS9 and 10 and his is faster than the CS1 and 2, so you can exclude the eccentric atrial conduction. But there is something you have to see. Here is the atrial signal in the high RA. The high RA came before the signal in his distal, so it is not likely to be eccentric atrial conduction also, because as you can remember from this slide, the concentric retrograde atrial conduction has the fastest atrial signal in the his region, the slowest signal in the high RA here. So it is not the concentric retrograde atrial conduction also. This one, the signals come from the high RA first, then goes back along into the HIS and the CS1 and 2. So this one is not likely to be Abnrt or Avianity. And you can see that from this pacing, the ventricular signal and the atrial signal is dissociated. So it is likely to be complete AV block. If it is a complete AV block, or if there is some block between atrium and ventricle, you can rule out the autonomic Avrt. I will talk about this in the next lecture about how to diagnose Avrt. Okay, this one is the pacing in atrial in the atrial area. Here is the pacing from the high RA. If you can see the spike, and it's capture the atrium, and you can see that in here there is in the his catheter there is this one is atrial capture, and this one is his signal 1 and ventricular signal. And in the next one here is atrial capture A2 and H2. You can recognize that some duration between A1 and H2 and A1 and H1 is different. The A1 and H1 is around 78 milliseconds, then A2 and H2 is 97 milliseconds. So this one is called decremental conduction of the AV node. It is a rate-dependent prolongation of AH interval. It is because you pace faster. If you pace faster or the heart rate is faster, the AH interval could be longer, slightly longer, because the AV node has a decremental conduction property, which used to slow the ventricular rate when there is some tachycardia above it. This is a physiologic, a normal AV node conduction. The keyword is decremental conduction. So if the patient has the dual AV nodal pathway, we would see what we call an AH jump. An AH jump is an increase in AH interval more than 50 milliseconds caused by a decrease in coupling interval of extra stimuli by 10 milliseconds. This is when you pace, if you pace the patient with the cycle length of assuming that you pace from the atrium with the cycle length of 350, you have, and you measure the AH interval in his catheter, and it is around 100 milliseconds. Okay, if you pace 350 and you measure the AH interval, AH here, you measure it, it is around 70. And if you pace 340, you pace it faster. And you see that if the AH, you measure the AH interval, and the AH interval jump into 130. So the AH interval increased more than 50 milliseconds. This is called the AH jump. This is one of the dual AV node physiology. How it is occur? It's because when you pace at the rate of 300 milliseconds of the cycle length, the signal travel along the fast pathway of AV node. So you could see that the AH interval is 70 milliseconds. But when you pace faster for minus 10 milliseconds of the cycle length, the signals result in the transmission through the slow pathway. So the AH interval increase because the signal travel more slow, and it have to increase more than 50 milliseconds to identify that it is an slow pathway conduction. Anyone have any questions about this slide?
อาจารย์คะ Can I ask you about the previous question ค่ะไอ้สไลด์หน้า40อะค่ะ
This
Why
one?
it is not another one in the previous slide?
Or this one?
Yes. Why it
Okay.
is not concentric อะค่ะ
Because the high RE come first. Here, high RE come first. If it is concentric, it has to be in his catheter. Atrial has to be come first in his catheter, and RA is slower than his. You can see it here. So this one is not concentric. This one is and this one is the signal from high RA downward. This is not a retrograde atrial conduction. I put this slide into to for you can see that you have to identify the signal in the high RA also, not only in the HIS and the CS. Okay, is it clear?
yes ค่ะขอบคุณค่ะอาจารย์
And this one is also not the retrograde signal, because you see that there is dissociation between the ventricle signal and the atrial signal. This tracing come from complete heart block patients. So the signal cannot travel up from the ventricle to the atrium and the atrium down to the ventricle. So this one is not retrograde also. Uh, you have to see the pattern, and you have to think that is it a really retrograde or it's an anterograde. And if you could identify that it is dissociation, there's some dissociative between it, so it's not a retrograde one. Just this is maybe it's too complex, but just an example that you have to see all the catheter to identify the atrium. Okay, so everyone understand about the AH jump. If you find the AH jump during the EP study, you could tell that the patient has dual AV node pathway, but you could not tell that this is the cause of tachycardia, because there are some people, like I said before, 15% of the normal population, they have the dual AV node pathway, but some of them do not participate in the tachycardia. Here is the AH jump. In the X plane here is the A1, A2, is when you pace faster. This is the cycle length of pacing. And I'm sorry, in the X plane, this is the cycle length of pacing, and in the Y plane, this is the measure of AH interval. You can see that when you pace from 300 milliseconds of cycle length, there is a jump here. The AH interval increased more than 50 milliseconds, so there is an AH jump in this patient. And before the AH jump, you can see that the AH interval increased during the faster pacing. Here, the AH interval is increasing, but not more than 50 milliseconds during the in decremental of the pacing 10 milliseconds. So this one here is a normal decremental property of the AV node. Here is the definition that you have to remember. Okay. This is another example of AH jump. Here is the pacing from the high RA. You see that this is the A1 and H. AH interval is 115 milliseconds. And you pace faster for 10 milliseconds here. You pace faster, and this result in an increase of the AH interval into 285. So it is more than 50 milliseconds. This patient has an AH jump. So you can diagnose that this patient has a dual AV node physiology. And also in this one. This one is another dual AV node physiology that you could encounter. When you pace here, S1 here. You see in his catheter, you see A, H, and V here. And when you pace faster, you see A2, H2, and V2. This one is not jump because the AH interval is not more than 50 milliseconds. But here you see that this one is occur. What is it? There's no A in front of it, but there is H2 and V2 again. This is another type of dual AV node physiology. We call it 1 for 2. You see in the right side here of the picture, you see this is the A2. When you stimulate the atrium here, the signal travel along the fast pathway, resulting in the first H2 and V2 here and here. And there is some parts of the signal travel along the slow pathway here, and also result in another H2 and V2 here. So this is called a 2-for-1 response. You pace only one atrium, but it results into 2 His signals and 2 ventricular signals. So in this patient, there must be 2 pathways inside the AV node. It is 2-for-1 response. It is one of the kind of dual AV node physiology that you could encounter if the patient has both fast pathway and slow pathway. And another type of signal that you could encounter if the patient has dual AV node physiology is the typical AV nodal echo beat. So what is the echo beat? Echo beat is when you pace faster. Here, this one is when you pace the first one. The first one, and the signals travel along down into the fast pathway and to the ventricle, and you see that it is in this one. And when you pace faster here, you pace faster, the fast pathway is still in the refractory period. So the signal travel along the slow pathway here, and you see that the signal travel along the slow pathway and down into the ventricle here. But when the signal reach the fast pathway, the refractory period has already recovered. The signals from the slow pathway could travel up to the fast pathway and up into the high right atrium, but do not generate the tachycardia. This one we call it an echo beat, a typical echo beat of the AV node. This is another signal that you could interpret it as the patient has a dual AV node physiology. Anyone has any questions about this?
อาจารย์คะขออีกรอบได้ไหมคะ
Okay. Okay. You see here, you have to see both of the EGM and the picture at the same time. I will try to explain it. This one, we paste this one is here in this one. We paste this one, and the signal travel from the atrium down the fast pathway of the AV node and down to his and ventricle and result in this one. This one is atrium. This one is his, and this one is ventricle. And when we pace faster, this one is A2 here. We pace faster. The fast pathway here is still in a refractory period, so it could not conduct the signal. So the signal have to go along into the slow pathway here. Here is the signal goes along to his and to the ventricle by slow pathway. Here, you can see here. And when the signal traveled along the slow pathway, the fast pathway is recovered. The fast pathway here is recovered. So when it reached here, the signal from slow pathway could travel down to the ventricle, and also some of it could travel up into the fast pathway and reach the atrium. We will see then in the EGM that there is some path of the retrograde atrial activation here in the CS and reach the high RA. This one is the retrograde signal, which came from the fast pathway that have already recovered. So we call this beats an echo beat. Is it clear for you?
เคลียร์แล้วค่ะขอบคุณค่ะ
If the patient doesn't have the slow pathway, this would definitely not occur because they don't have another limbs of the conduction. Okay, so this is the size of dual Avnrt physiology, and we would test this to confirm if the patient have dual Avnrt physiology or not, and after that we would pacing to induce the tachycardia to confirm that what type of tachycardia it is. So here is the pacing from proximal CS to induce the tachycardia. Here you can see that this is the pacing spike here, here, here. And after that, we stop pacing and the tachycardia occur. This is when we induce the tachycardia and to see the property of tachycardia. Okay, so this is again the typical AV node echo. As I have said before, that we pace faster and faster, and there is some echo beat occurs here. This one you could only tell that there is dual physiology in this patient. And this is the initiation of the Avianity. You pace from here. When you pace faster and faster, the AV node echo occur. And this is the A2 here from the last slide. Mostly if the echo occurs and it not initiate the tachycardia, you could only say that there is a dual AV node physiology. But if the echo occur and then the tachycardia initiate, you could definitely say that this one is likely to be an Avnrt. You see here in the slide here that this one, when we pace faster, the fast pathway is refractory, and the signal travel along the slow pathway, and it reached down to ventricle. And when the fast pathway recover, the slow pathway goes up into fast pathway. If it happen only this, if there's no any signals come after it, it is just an echo beat. But some of the patients, the signals travel up to the atrium and also could travel down into the slow pathway and up again into the fast pathway. This is the initiation of slow, fast, typical Avianity. So, the typical AV nodal echo could initiate the Avianity tachycardia. So this is the this example is the classic typical Avianity, which use the slow pathway as the anterograde limbs into ventricle and use the fast pathway as the retrograde limbs in the AV node. So what is the presence of classic slow-fast Avianity? First of all, if in the state that the tachycardia is not initiated, you must see the dual AV node pathway physiology. You you should see the AH jump. You should see if there is an echo beat. And after the tachycardia have already initiated, you should look into the retrograde atrial activation. It should be an concentric retrograde atrial activation in which the earliest atrial activation would come in the distal his or the proximal CS of 9 and 10 catheter. And also, like in the 12 leads ECG, the circuit of the Avianity is very small. So the VA interval should be less than 70 milliseconds. Measure from the atrial and ventricular electrogram line up. This is the example of typical Avianity. You see that this is and when you read the EGM, you read the ECG first. The ECG in the EGM is 10 millimeter per second, not like in the 12 lead ECG, which is 25. So you can see that the QRS complex is quite wider than in the 12 lead. This is a narrow complex tachycardia. And first of all, you have to identify what type of retrograde atrial activation in this EGM. You see which is the fastest retrograde atrial activation. You see that the fastest retrograde atrial activation is around here in proximal CS, and in his is quite similar in the rate. In the atrial signal comes first in the proximal CS 9 and 10, and later in CS 1 and 2 and high RA. So this one is concentric atrial retrograde activation. And after that, we have to identify the VA interval. What is the VA interval in this patient? The VA interval you measure from the signal of V to signal of A, and the VA interval is less than the 70 millisecond. So in this EGM, it is likely to be typical slow fast Abnrt. What about this one? Can anyone tell me? Can anyone read step by step for me? Okay, I will ask, what is the type of retrograde atrial activation?
Eccentric.
Yes, it is eccentric. It's comes the CS 1 and 2 came first. So this one is eccentric atrial activation. This one is not an Avnrt. It is an Avrt using left lateral accessory pathway. We will talk about this in the afternoon. Okay, so this one again is a narrow complex QRS tachycardia. And what is the retrograde atrial activation in this patient?
Concentric ค่ะ
Yes, this one is concentric atrial activation. But you can see that the VA interval is quite long. Here is V, and here is A. The VA interval is more than 70 milliseconds. So you cannot conclude that this one is typical Avianity. You have to do some manual to prove what is the type of this tachycardia. The differential diagnosis is still Avianity, but it could be a typical Avianity. The Abnrt or again or an atrial tachycardia with first degree AV block. How could it be atrial tachycardia with first degree AV block? It could be because if this atrium is not a retrograde atrium, you imagine that if this atrium is an anterograde from the atrial down to the ventricle here, but the distance between the atrium and the ventricle is quite long, so there must be some block between the atrium and ventricle. So the atrial tachycardia with first degree AV block could still be in the differential diagnosis. So we have to do more maneuvers to prove what the type of this tachycardia is. There is 3 maneuvers you have to remember, and you have to use for the diagnosis. The first one is the response to ventricular pacing during the tachycardia. To see the response, and the second one is the effect of PVC during his refractory period during tachycardia. And the last one is the effect of bundle branch block on tachycardia cycle length and the VA interval. I will speak slowly about 3 of these maneuvers. Okay, first we will talk about the response to ventricular pacing during tachycardia. If we have this tachycardia and we cannot differential diagnosis, we have to do the manual. We have to use the ventricular pacing during the tachycardia. We usually pace faster than the cycle length for 10 to 20 milliseconds and see the response after we stop pacing. On the left picture, it is an reentry circuit of Avnrt or orthodromic Avrt. And on the right picture, it is an atrial tachycardia, which the signals of the tachycardia came from the atrium down into the ventricle. The first one, the Avianity and the orthodromic Avrt. The signal goes up through the fast pathway. You can when we pace during the tachycardia, you can see that if we do the V pace, there's a retrograde atrium through the fast pathway, and we do another V pacing, we will see a retrograde atrium through the fast pathway also. And when we stop pacing and the tachycardia still resume, we will see that the V pacing would also not the V pacing, the V signal would also retrograde into the atrium, and then after that, okay, so we can see that it is a VAV response. Okay, I will explain it again. First of all, we do the we have a circuit of tachycardia, and the tachycardia is still running, and we pace from the ventricle, and it results in V-pacing and a retrograde atrium. And we do another ventricular pacing, and we have a retrograde atrium, and then we stop pacing. When we stop pacing, the signal from the atrium would go down back to the ventricle, and we would see that there is a ventricular signal. And again, the ventricular signal would goes up into the atrium. And what we want to see the response when we stop pacing here. So if it is a reentry circuit, we would see that it is a VAV response. This one could be Avianity or orthotomic Avnrt. But if the patient has atrial tachycardia, we pace from the ventricle and it goes up to the atrium. Okay, we pace again on the ventricle, it goes up to the atrium, and then we stop pacing. When we stop pacing, the tachycardia initiate from the atrium here, go back down to the ventricle. So it should be A and V. And we see the response after we stop pacing here. The response would be VAAV response. This one could give us that the diagnosis should be atrial tachycardia. Anyone has questions about these two response? Okay, so if there is no question, I would go to the real EGM. Okay, so this one we can identify here that we are pacing here. Here we are pacing here. We pace from V and then it retrograde up to A here. We pace from V and it goes up retrograde here. And then we stop pacing and the tachycardia resume. If it is a reentry circuit, the tachycardia, the signal of the A here have to goes down along into V and then goes up into A. So here is a V, A, and V response. This one, the VAV response could be Avianity or Avnrt, but it could not be an atrial tachycardia. And from this one, the VA interval is very short, shorter than the 70 milliseconds. So from this one, you can tell that it is typical Avianity. So what about atrial tachycardia? You see that this is ventricular pacing. You see that it is a pace beat. You pace here, and you stop pacing, and the tachycardia resume. And you pace here, and it retrograde to atrium. But the atrial tachycardia is not a reentry circuit inside the AV node. The initiation of the tachycardia have to be from the atrium. So you could see that this is the signals from the atrium down to the ventricle. So this is the response of the VAAV response. If you see this response, it is an atrial tachycardia. Anyone, is it clear for anyone in this topic? Okay, if there is no question, I would go along. In this one is narrow complex tachycardia with a concentric atrial retrograde activation with a VA interval more than 70 milliseconds. So we cannot tell what type of the tachycardia it is. It could be Avianity, Avrt, or AT with first degree AV block. So we do the ventricular pacing to see the response. And what is the response in this patient? Can anyone answer me?
VAAV.
Yes, it is. It is V here, A here, A here, and V. So what is the diagnosis of this patient?
Atrial tachycardia.
Yes, it is. It is atrial tachycardia. Okay, you get it right. And again, this is the EGM of narrow complex tachycardia with ventricular pacing. Here, when we stop pacing, this is V, and this is A, and this is V. So this is VAV response. The differential diagnosis still be Abnrt or Abrt. But in this patient, the VA interval is very short, shorter than second millisecond. So you can tell that this is a slow, fast Abnrt. So this is the first response you see from the ventricular pacing. The second response you have to see from the ventricular pacing is the post-pacing interval. So the first thing you need to know about post-pacing interval, the word is the entrainment. Entrainment, what is the entrainment? Entrainment is the maneuver that allows you to distinguish one type of reentrant arrhythmia from an a mechanism of automaticity or trigger arrhythmia. And after the reentry has been confirmed, the entrainment pacing could permit you to know that is the catheter you put in is in the site of reentry circuit or not. The entrainment is the same as when you put the ventricular pacing during the tachycardia. As the last slide, you pace ventricular pacing, or you pace from anywhere else during the tachycardia, and the tachycardia still resume. It is called the entrainment. So what is the usefulness of post-pacing interval? This slide shows that if you put the catheter into the circuit during the tachycardia, assuming that the tachycardia has the cycle length of 400 milliseconds, and the red star shows that the tachycardia still running with the cycle length of 400 milliseconds. And after that, you put the catheter into the circuit, and you pace faster than the tachycardia of the cycle length of 350 milliseconds here. And after that, you stop pacing. And the tachycardia resume. Here, between the duration between the last pace beat and the initiation of the tachycardia, of the resume tachycardia, is called post-pacing interval. Here is the post-pacing interval. If the post-pacing interval minus the tachycardia shorter than 30 milliseconds, this means that the pacing site that you put the catheter in is near or in the reentry circuit. Why it is near or in the reentry circuit? You imagine that if you put the catheter in here, around here, and when you pace and you stop pacing, the post-pacing interval is the time from the circuit here to deliver the signal to the catheter here. If the catheter is near the circuit, the post-pacing interval would be short because the distance between the circuit of reentry and the catheter you put in is short. So the post-pacing interval minus tachycardia cycling would be short too, and it would be less than 30 milliseconds. But if you put the catheter far away from the circuit here, assuming that the tachycardia in the red stars is around 400 milliseconds and it is running, and you pace from outside the circuit with 300 milliseconds. And after you stop pacing, the tachycardia resume, but the post-pacing interval is quite longer than the last one. This because if you stop pacing, the signal from the circuit, which is post-pacing interval, have to travel from the circuit to a faraway catheter here, then would likely result in a long post-pacing interval. And this would result in post-pacing interval minus tachycardia more than 30 milliseconds. If this formula is longer than 30 milliseconds, you can tell that the catheter you put in and you do the entrainment is far away from the circuit. Anyone has questions about this one? Okay, if there's no question, I would go to the next slide. So, what is the benefit of entrainment from the RV apex? We use this to differentiate diagnosis between the Avrt and the Avianrt and the Avrt. Because if you can see from the last maneuver, the ventricular pacing, and you stop to see the response, the VAV response could be both Abnrt or Avrt. The next thing we have to do is to see if the post-pacing interval is short or long. If it is Avnrt, the reentry circuit is in the AV node, which is here in this area. And the catheter we put in is RV catheter to do the entrainment is here. So the distance between the reentry circuit and the catheter is quite long. If it is the Avrt, you put the catheter in the RV apex is here, but the reentry circuit is a large reentry circuit between the ventricular and atrial. The catheter and the reentry circuit distance is quite short, so this would likely result in a shorter post-pacing interval than the Avnrt. Yeah, the RV apex is closer to the circuit of Avrt than in the Avnrt. So what is the response? The RV aspect is closer to the circuit of Avrt than the Avnrt. So the post-pacing interval of the Avrt is likely to be shorter than the Avnrt. The formula of post-pacing interval minus tachycardia cycling is less than 150 milliseconds, likely to be orthodromic Avrt. But if the post-pacing interval minus tachycardia cycling is longer than 150 milliseconds, it is considered to be Avnrt. Is it clear about this one? Okay, no question. So I will go to the real EGM. So this one we do the RV pacing or the entrainment. We do the RV pacing, and the tachycardia still resume. And we see that the response of the pacing after we stop is VAV. So it is still could be Avianity or Avrt. The next thing we have to see is the post-pacing interval. The post-pacing interval is in the red box here. It's the duration between the last pace beat and the first of the tachycardia. Here is 600 and 600, 600 around 600 milliseconds. So it is quite long, and the tachycardia cycle length is 400. So we use this to PPI minus tachycardia cycle length. It is more than 150 milliseconds. So this one we can conclude that it is typical Abnrt. But if this one, the post-pacing interval minus tachycardia cycle length is less than 150 milliseconds, it is likely to be Avrt. Okay, so this is the second maneuver second response we use to differential diagnosis the type of SVT. The next thing we could do is we put the PVC during his refractory period, during the tachycardia. So what is the PVC during the his refractory period? You know that when we have a tachycardia, when the signals travel along the his, and after it passed the his region, the his would be in the refractory period. This would result in a difficult or no electrical signal could activate any cells around the his region. If it is the Avnrt or AT, there is only one pathway through the ventricle. The Avnrt or AT, if it is the Avnrt, the circuit, the reentry circuit is here, and here is the his region. So there is only one pathway after the reentry circuit down into the ventricle. If there is some refractory period in the his, the signal cannot, if we put the PVC in, the PVC could not retrograde into the his region to reach the atrium. This would result, nothing would happen to the tachycardia. But if it is Avrt, there is another circuit here, another circuit of the bypass track here. If you put the PVC in, actually PVC could not travel to the his, but the PVC still could travel along the accessory pathway up into the atrium. So this PVC would result in resets of the circuit. So which is it a right side AT or Avrt? I will ask you first, what is the retrograde atrial conduction in this patient? What is the fastest signal in which catheter?
Is it concentric in his?
No. You see this one? You
High
see the
RA.
yes, it is high RA, so it is not concentric. The signals come from the high RA first. So the differential diagnosis of the tachycardia is the right side AT or the Avrt using right side accessory pathway. So but you cannot tell from this EGM which is which. And so we use the PVC to see if there is any response to the tachycardia. This is the PVC we put in here. Here is the PVC. And the response we would see if the first response is that can the PVC do anything to the circuit by identifying the atrial signal after the PVC. If the PVC could advance the atrial signal, or could delay the atrial signal, or could break the circuit, you can diagnose that it is the Avnrt. In this slide, the PVC was thrown during the His refractory period, and you can see that the duration between atrial to atrial during the tachycardia is longer than the duration of the atrial after the PVC. We can conclude that this PVC could travel up into the atrium. So it is likely that there is another accessory pathway which is not the normal His and AV node pathway in this patient. So we can conclude that this patient has a right side accessory pathway. Anyone has questions about this? Okay, so we will see another example. This one is called reset of the AA cycle length. If the PVC could reset the cycle length, there must be an accessory pathway in the patient. This is the RV pacing during the tachycardia also. And this one has an AA interval during tachycardia. And another one is, you can see that this PVC has reset, has no effect on the circuit because the AA interval is still the same. So we can conclude that the PVC during His refractory period has no effect on this circuit. You could tell that likely there should not be any accessory pathway in this patient. So this patient, we diagnose that he has a slow fast Avnrt. And the last effect of the EPS that we have to differential diagnosis of the SVT that we want to see is the effect of the bundle branch block on tachycardia cycle length and the VA interval. So this is the bundle branch block during tachycardia in patient with AT or Avnrt. If the patient has AT or Avnrt, the bundle branch block has no effect on the VA or the cycle length of the tachycardia. But if the patient has the Avnrt, which is the large reentry circuit here. Here is the reentry circuit of the Avianity. When there is a bundle branch block, here is the bundle branch block on the left bundle branch. The signals from the reentry could not travel down the left bundle branch, so the signal escape into the right bundle branch, and then the signals goes up through the myocardium and went up into the signals again. This effect would increase the VA conduction time because the signal have to detour into the right bundle and goes back up into the left side of the circuit. So the VA conduction time would be longer. You can see that in this tachycardia on the left side here, and the side here, is the left bundle branch block, and the VA interval is 120 milliseconds. And after the bundle branch block have result in a narrow QRS complex again, the VA interval is shorter. This one, if you see this response, you could diagnose that the patient has Avnrt, not the Avianity or the AT. And also, the tachycardia cycling is shorter during the tachycardia after the bundle branch block resolve because this also happens because the signal have to detour into another bundle branch. This have the name of the effect. We call it Kuhlmann's sign. This one you have to remember, Kuhlmann's sign. So after we have confirmed, after we have done all the manuals and we confirm that it is Avnrt, we have to treat the patient, and the definite treatment of Avnrt is the ablation. So what is the site of ablation of the Abnrt? The site of ablation we target is the site of slow pathway. We don't in the past some doctors target the fast pathway, and that result in a lot of AV block after the ablation. So the site of ablation of first we have to identify where is the triangle of Cork. The easiest way to identify is to identify the His signal in the ablation catheter. You can see that this is the His signal. You know that if it's the His signal, there is an AV nodal there, and the AV node is on the top of the Cox triangle. So we move the catheter rightward and downward. Here around here is the AV node. Here is the AV node, and the His is around here. And we move the catheter downward until you didn't see the His signal. This is the ablation side, the slow pathway side, which we would like to do the ablation, and it is safe to do it because it's quite far from the AV node. So if after during the ablation there is some heat that could radiate to the AV node, and that would result in accelerated junctional rhythm. This accelerated junctional rhythm could tell us if the ablation catheter is on the site, and we can use this accelerated junctional rhythm to monitor if we have to stop ablation or not. Because if the junctional rhythm is very, very fast, that could tell you that there is too much heat into the AV node, and you have to stop the ablation before there is a complication of heart block. So the junctional beat during ablation is important. There are types of junctional beats during the ablation. If the junctional is irregular and very rapid junctional, it is the site of ablation is a compact AV node. You should stop ablation. It tells you that you have identified a wrong area. If the junctional is rapid, greater than 100 beats per minute, and regular, it is fast pathway. This one, you could ablate this one, but you have to be careful because if you ablate fast pathway, there is more complications than the slow pathway. The junctional that we would like to have is a slow regular junctional beat with conduction from atrium and both atrium and ventricle. This tells you that it is a junctional from a slow pathway. A change in retrograde activation sequence is the change from fast to slow or slow to fast pathway. This would give you a clue that there might be some dislocation of the catheter you put in. You may have to stop and re-evaluate before you ablate again. Some people would do the atrial pacing to capture his to see if it is a normal conduction through the AV node or not during the pacing. If during the pacing, if you do the atrial pacing and it is captured AH and his and then after that there is no conduction to be during the ablation, it can tell you that you have some problem with the location. You must have contact into the AV node. You must stop ablation. And also it can tell you that if the AH interval have come back from have shortened from a long AH interval to a normal AH interval. This tells you that the slow pathway of Avianity have been demolished already, and it is a successful point of the ablation. So this is accelerated junctional rhythm and atrial pacing with a capture, his, and normal AH interval. On the left side, this is the start of the RF application. You can see that this is still a normal sinus rhythm. I have to tell you first that you could ablate during the tachycardia, and you could also ablate during the sinus rhythm after you have terminated the tachycardia. We like to ablate during the sinus rhythm because we could identify the hits and we could identify the signals easier than during the tachycardia. And after we do the ablation, we could see that there is an accelerated junctional rhythm here. Usually we evaluate that if this junctional is regular or irregular, how fast it is. And after there is a junctional tachycardia and the junctional has stopped, we do the atrial pacing to evaluate the A to B response and also to evaluate the AH interval. If the AH interval come back to normal duration, it is likely that we have successful ablation. This is accelerated junctional rhythm with VA block during the ablation. This is the junctional rhythm with V and A. There is V and A. And during the ablation, there is some prolongation of VA interval, prolongation, and then VA block. This is not a good sign. this shows that there is some blockage in the AV node. If we see this, we have to stop ablate because there's a risk of injury to the AV node. So how can we approach to the slow pathway? The target of slow pathway is the isthmus tissue between the tricuspid annulus and the CS ostium. The ablation catheter is advanced into the RV and moved inferiorly and anterior to the CS ostium to see the large V EGM and the ratio between the A and V amplitude ratio during the sinus rhythm in the EGM is about 0.1 to 0.5. And the catheter contact the low atrium septum. The target site of ablation, as I said before, is a slow pathway potential. If you can see the potential, that is good. But if there is no potential, you use the ratio of A to B 0.1 to 0.5 as a position of ablation site. The slow pathway potential is recorded at mid-anteroseptal position. And we deliver the radio frequency energy. We usually, if we have induced the tachycardia by using the medication of isoprostanoid, we usually stop it first because if the patient is still on the medication, there would be hyperdynamic contraction, and this would result in the dislocation of the ablation catheter and also could result in the injury of the heart. Ablation during normal sinus rhythm is easier to maintain the catheter position and easier to see the signal of the catheter. The maximum power would be 50 watts, temperature around 55 to 60 milliseconds. Around 30 to 60 seconds is enough to eliminate the slow pathway. We ablate until the junctional rhythm occurs, and we observe the junctional rhythm, if it is, how fast it is, regular or irregular, and is there any VA block during the junctional rhythm occurring. Accelerated junctional rhythm typically develop within few seconds after RF ablation. The mechanism of junctional rhythm is the enhanced automaticity of AV nodal tissues from thermal injury. And what is the endpoint of the ablation? The first one is complete elimination of slow pathway conduction, or the dual AV node physiology. There is the tachycardia cannot be induced. There is disappearance of discontinuous AV conduction curve, or you can say that there is no dual AV node physiology, and there is Wenckebach cycling in the AV node, and the AV node is blocked when you pace faster. You cannot detect the echo beat. You cannot detect the AS jump. This is the complete elimination of the slow pathway production. There is another type of endpoint that could be reached. It's called modification of slow pathway. The pathway could not conduct the tachycardia, but you could see some form of dual AV node physiology. You could see one echo beat and one jump. It is acceptable that there is still one echo beat or one jump, but could not induce the tachycardia. This is called slow pathway modification. This one is another endpoint that we could accept. I prefer to do modification rather than a complete elimination of slow pathway, because if you put more energy into the AV nodal area to eliminate all the slow pathways, there would be more risk to injury the AV node that would likely result into complete AV node, AV block in the patient. And endpoints, you have to preserve the fast pathway, Retrograde and Retrograde conduction, because it is essential for the AV node to use fast pathway to deliver the signal into the ventricle. For the complications of the ablations, there is risk of AV block around 0.2 to 0.6%. And how we can predict the AV block? Proximity of anatomy ablation to the site of compact AV node. You are really too close to the AV node, so there's a risk of AV node block. If the junctional rhythm is very fast, the cycling is less than 350 milliseconds during the ablation, this is likely you have too close to the AV node. The junctional rhythm with VA block is the risk of complete heart block, and the worsening of anterograde AV conduction during the RFA. As I have said before, if you pace from the atrium to the ventricle during the RFA, and the AV conduction is worsening, for example, the AH interval is longer and longer. This is not good. This means you have be too close to the AV node. And the outcome of ablation by the anatomic guide is more than 95%. The recurrent rate is 2 to 5%. The recurrence of Avianity usually occurs within first day to month. So the success rate is very high, more than 95%. This is the standard treatment of Avianity is the ablation, because the success rate is very high and the complication is very, very low. So this is all for the morning session. Anyone has any questions about this lecture? You don't have to worry much about the EGM, the electrogram. It takes time to learn, and you have to read it often to be familiar with it. Even with the cardiologist or the new trained fellow is still confused about it. So you don't have to worry much about it. So if you have any question, you can ask me now, or you could send me a question in my email that I have given to your friend. Okay, if anyone has any question? Or if you have any cardiac electrogram you want to ask me, you can send me an email and I will answer it for you. Okay, if there is no question, we would have a break, and for the afternoon session, I think I would start at 1 p.m. Is that okay?
ได้ค่ะ
Okay, so thank you for your attention. I'll see you in the afternoon.
ขอบคุณค่ะ
ขอบคุณค่ะอาจารย์
ขอบคุณค่ะ
ครับสวัสดีครับ